In today's episode, we are going over an evidence-based guide to physical therapy rehabilitation after arthroscopic rotator cuff repair surgery. Let's do it. All right, so what's the problem with rotator cuff repair surgery? Well, first and foremost, rotator cuff related pain is the number one most common type of shoulder pain reported in the medical literature. It is extremely common, and therefore the repair is actually common as well. One of the issues with rotator cuff repairs is that they will often re-tear, and the rates are highly dependent on the type of tear. However, in some studies are as high as 94%, right? So essentially, almost 100% of all rotator cuff tears in some studies will re-tear over the course of time, right? And this is not common for the majority of rotator cuff repairs, obviously, but it does end up getting a little alarming from a physical therapy standpoint because we actually do know that what we choose from a physical therapy perspective to do with our patients will influence their outcomes and also influences whether or not they re-tear over the course of time, right? So if I go too fast, am I going to cause a re-tear? If I'm not going fast enough, will I not facilitate healing, right? What should a physical therapist do? The other piece that becomes very, very confusing is that there's a huge variance in different protocols in patients that have rotator cuff repair surgery. You may have one patient that comes in and the physician has no sling on the patient and active range of motion starts at, let's say, 4 weeks. And you might have another patient that comes in at week 10 and they were in a sling for 6 weeks and they're not allowed to do any sort of strengthening until they get to month 3 or month 4 even, right? So there's huge variance between different protocols. And the other piece is that the medical literature is relatively clear in the sense that some tears can potentially be pushed a little faster than others. So it's not just like every single rotator cuff tear repair should be treated the same, right? And the thing is, as physical therapists, we want to try to optimize our outcomes, we want to minimize the risk of re-tears. So how the heck should we go about this? What should physical therapy rehabilitation look like? And what should be those differences from patient A to patient B with different size tears, different occupations, going back to different sports, et cetera, et cetera. So in today's episode, we're going to go over outcomes following rotator cuff repair surgery. Does the surgery work well? Are patients happy, satisfied? Do they get back to their sport after they finish up getting the repair surgery? Should you immobilize and put a sling on the shoulder following rotator cuff repair? When should you initiate range of motion exercises? And this goes for passive range of motion as well as active range of motion. Is there a difference between accelerated physical therapy program and more standard or conservative programs? What are factors that are going to influence the rate of progression and also healing rates? And lastly, what are return to sport times and rates? Are people returning back to sport? Are they getting back to the same level as did before? Is there a difference between different types of sports, right? And lastly, how about barbell athletes? So the folks that we love working with, as physical therapists that really enjoy strength and fitness. Now, before we really get going, I want to let you know about a free resource. I have made a rotator cuff tendinopathy and rotator cuff tear evidence-based cheat sheet for you to check out. It's 100% free. I'll put a link in the show notes. You can check it out. We go over rotator cuff tear prevalence, anatomy, the difference between a tendinitis and tendinosis. We go over risk factors for tears and tendinopathy. We go over the clinical presentation, common tear types, rehab expectations, as well as surgical candidates. So who is the best candidate for rotator cuff repair surgery? Because not all folks are going to need surgery. So we'll go over all of that in this cheat sheet. I'll leave a link in the show notes, 100% free. Go grab it. And welcome to the Fitness Pain-Free Show. This is where we help coaches and physical therapists like yourself get your patients out of pain and back in the gym where they belong. My name is Dan Pope. I'm a physical therapist. I'm a coach, personal trainer, and a meathead. I love all things fitness. I have my dream job as a physical therapist, coach, business owner, and educator, and I've been doing it for a few decades now. My goal is to help you reach your goals so you can be as happy as I am. Now, I want to put a little standard disclaimer in the mix here. If you are an individual that just had rotator cuff repair, this is in no ways a guide to your rehabilitation, all right? You definitely want to try to get guidance from a physical therapist or surgeon. Do not take my advice. Do not go ahead and just do everything that I talk about here today. I think it's very important that I state that. The second piece is that I am not going to include a protocol here. This is not going to say week 2, start this, week 4, start this. I'm really kind of summarizing the evidence and just helping you to critically reason as a physical therapist or coach to try to figure out what's best for your patient, right? If you want some really good in-depth information on how to treat rotator cuff repairs, I highly recommend you checking out anything from Kevin Wilk. I call him the rotator cuff repair master. He has a ton of great courses out there, lots of good free information as well. Go into Google, throw in his name next to rotator cuff. You'll find all sorts of great stuff. And lastly, if you do want a decent protocol, I find myself recommending the protocols over in the University of Delaware quite a bit. And I'll leave those protocols as a link in the show notes if you want to check that out. They have a bunch of really good protocols for rotator cuff repair. So, what are the outcomes following arthroscopic rotator cuff repair? Basically, do these patients do well? Do they get back to their prior level activity? Are they satisfied or happy with the repair? So, generally speaking, yes, right? But I always look at these studies when they say there's a good outcome, and I wonder, what the heck does good even mean, right? So generally, you'll find improvements in people's pain, in their function, in the reported quality of life. Also, they'll have improvements in shoulder-related outcome measures, and all that is good stuff, right? Another stat that I actually really enjoyed was that 90% of patients are satisfied with surgery 6 months after surgery, and this was maintained at 5 years, right? I think this actually is a big tell because if you're considering whether or not you should go ahead and get rotator cuff repair surgery, it kind of helps to know that most people are pretty satisfied with the surgery. Generally speaking, in the social media world, I think there's a big push, at least from physical therapists, not to perform surgery, right? And this is not the discussion for today of whether or not you should get a rotator cuff repair and which ones should be repaired and which ones shouldn't. But largely, I think we're very fearful of getting repair. But the other piece is that folks that do get this tend to do pretty well, despite some of these high re-tear rates. And we'll talk about this a little bit later. The discussion is nuanced, right? But I will say overall, I found that folks had really good outcomes in the medical literature. Personally, as an anecdote, I think most folks do pretty well after rotator cuff repair that I've worked with too. So there you go. So how about return to sport after rotator cuff repair, right? Let's say you're not a 65-year-old sedentary individual, right, who's just getting rotator cuff repair surgery because their shoulder hurts all the time. You actually can't do the sport that you love, and you would like to not only get out of pain, but also try to get back to your sport. And you'd like to get back to the same level or a higher level than you were prior to getting hurt. What are the outcomes for athletes? Well, generally speaking, they're quite good for athletes as well, and they have improved outcome measures, improved pain, improved function, and their quality of life also goes up, right? And that's good stuff. We'll talk a little bit more about the specific return to sport rates because it's a little bit different, competitive versus, let's say, recreational. It's going to vary based on the sport as well, right? But generally, about 87% of athletes will return to sport after rotator cuff repair. Pretty good. And about 80% will return at the same level prior to surgery. And this is actually super important because if you compete at a very high level of sport and you get hurt and you get a rotator cuff repair, if you're not getting back to the same level of sport, I wouldn't call that a successful procedure, right? I think a success would be you get out of pain, you get back to your sport, and you get back at the same level of play, right? So generally speaking, most folks are returning back, and this is a nuanced discussion. We'll talk about this a little bit later. But it's not like every single person has a cuff repair and they get back exactly the same way they were before. I think this is sometimes a good expectation for docs to talk to their patients about is that this will help you, but may not get you back to 100%, right? But there's a good likelihood it will. So guys, if you like what you're learning about so far, then I want you to go and check out the Fitness Pain-Free Mini Course. So I made a mini course. It's absolutely free. That's the next logical step if you want to learn more from me. So in the course, we go over 5 lessons. That first lesson is how traditional schooling has failed us, right? So schooling is phenomenal from a physical therapy perspective, but doesn't really teach you how to work with high-level athletes in the fitness world, right? Doesn't always teach you how to do the lifts appropriately. Doesn't teach you about progressions and regressions of common lifts within the gym. Doesn't teach you how to program normally, how to write rehab programs, or how to write injury prevention programs for these folks. Next thing we go over, 7 reasons why people get hurt in the gym, 4 simple steps to getting your clients out of pain, how to build the career of your dreams and earn the respect of your community. It's all well and good if you know exactly how to work with folks within the gym. But if you can't get these folks through the door on a regular basis, then you're simply not going to be living the dream that you want to because you can't get the patients through the door that you want to work with. Okay, so I'll show you how to do that. And lastly, we'll talk a little bit about the fitness pain-free certification, right? So I'll leave a link in the show notes. I definitely recommend checking this out. So what are the re-tear rates like after rotator cuff repair? So what is a re-tear? So essentially, if you have rotator cuff repair surgery, then after the surgery, at some point following the surgery, most tears are happening somewhere between 0 and 6 months after you have a rotator cuff repair. If you have the tendon partially tear again, or fully tear again, or fail in the sense that maybe it never took in the first place, they would call that a re-tear or a failure, right? And we got some research to show that these re-tear rates are somewhere between 11% and up to 94% of all rotator cuff repairs will re-tear, which is kind of crazy. The overall rate is going to be around 17% at 6 months. The majority of folks that are going to re-tear, they will re-tear within the first 6 months. So probably is capturing most of the folks that do re-tear, right? And the thing is, the larger the tear, right, the more likelihood there is that you're going to re-tear over the course of time. So only 5% of partial thickness tears will re-tear. 27% of full thickness tears will re-tear. And the large, massive retractive tears are really the ones that are likely to fail again in the future. Okay. The other piece about rotator cuff repair rehabilitation that's kind of funky is that if you have a repair and afterwards it re-tears, chances are you're still going to have a good outcome, right? So I'll say it again because it's a little bit confusing. Let's say you have two patients, right? They both get rotator cuff repair surgery. At the 6 month mark, one person re-tears and the other person doesn't. And neither of them have any sort of insight into whether or not the repair is actually, working at this point. They're going to have a similar outcome generally. Okay. And this is going to kind of depend on the study that you read. But what's really interesting about these is that once you repair a rotator cuff, even if it does re-tear, chances are you're still going to have an improved outcome over not doing any repair whatsoever. So the first topic I wanted to talk about is whether or not you should wear a sling after surgery and how long should you keep that sling on, right, to stay as safe as possible. Now, I was looking at a study by Matlack et al. In 2021, so a relatively recent study. It was actually probably the most recent kind of a meta-analysis on the topic that I could find. And it was a systematic review. So they took a whole bunch of different studies and they lumped them all together. And they were looking at between small and large tears. And this is actually pretty important because one of the take-home messages that we'll go over in the next few lessons is that there's a difference between the way you treat a small tear and the way you treat a large tear. But in this study, they included small all the way up to large full thickness tears. They did not include any massive or fully retracted rotator cuff tears from what I can see. Okay. What they were looking at was early versus delayed use of a sling, right? So early basically means that as soon as 24 hours after surgery, you're not wearing the sling. In the other group, these folks were wearing a sling for at least 4 weeks, right? So what happened? At the 6 and then again at the 12-month mark, there was no difference in outcomes between the two different groups. In another study by Tirefort et al. In 2019, they were looking at the same thing. So basically, no immobilization, no sling whatsoever, versus wearing a sling for the first 4 weeks. And afterwards, we start to ditch the sling, right? They were looking at small to medium tears. So they weren't looking at large tears like the last study was, right? And what they found is that there was better early mobility and functional scores in comparison versus sling immobilization. So essentially, if you wore a sling, you'd get a little bit stiffer, right? So post-operative immobilization with a sling may therefore not be required for patients treated for a small or medium tendon tear. Now, I really wanted to find a study to compare against these two types of tears. So basically, we had small all the way up to large tears. I would have loved to see a study that included some massive tears, some fully retracted tears, and then adding in a sling to see if that influenced re-tear rates over the course of time. I couldn't find any, but suffice to say that between, let's say, a small to a large tear with the two studies that we just included, seems like using a sling is one of those things that doesn't seem to influence outcomes too much. And if you do wear a sling, it might actually make you a little bit stiffer and reduce your outcomes. So early versus delayed motion after surgery. So in order to try to figure out an answer to this, I took a look at a study by Xu Zhang et al. In 2018, and that was looking at 8 different trials of 671 patients. And they were doing early versus delayed passive range of motion. And the way they defined the passive range of motion was essentially performing passive range of motion less than 2 weeks from surgery. And then the delayed motion group was performing passive range of motion greater than 2 weeks, right? So essentially, early guys did passive range of motion, started somewhere between 0 and 2 weeks. And the delayed guys did passive range of motion started after 2 weeks, right? So in the early protocol group, they actually had superior range of motion. However, that may adversely affect the shoulder function. So the folks that were in the early protocol, they tended to have a little worse outcome, right? And the last piece that was actually very important is that the early passive range of motion might result in lower rates of tendon healing with large size tendon tears. So in the small to medium tears, this might not be an issue, but in those larger tears, it looks like it may be a concern. So, what the heck were they calling passive range of motion in these studies? So, if you're watching this on YouTube or the video podcast version of this, I put up a really nice chart or table here, which shows what these studies were using and calling passive range of motion. I'll just read off the first study because there's multiple studies included in this main study. So essentially, the early passive motion group was allowed to perform pendulums, manual passive range of motion. They also were using a CPM machine, and they had no restrictions whatsoever in terms of how far they're allowed to bring the shoulder. So there's no limitation in the flexion range of motion, external rotation range of motion. Just go for it, basically post-op day 2, right? Now, in the delayed passive range of motion group, these folks were actually doing a little bit of passive range. They were doing some pendulums. They're also giving some hand, elbow, and wrist range of motion exercises, right? So when you're looking at the passive range of motion group that did passive range early, they just had more range of motion, right? In the delayed group, they were actually doing some passive range initially. It's just that they had to wait a little bit until they had a physical therapist move their shoulder a little bit more, okay? And this was pretty consistent with the rest of the studies, but take these big meta-analysis with a grain of salt, just because they're taking a lot of studies together and they're just trying to figure out which studies use this kind of early passive range versus delayed passive range. But the definitions of passive, the exercises used, when they're allowed to start them versus how long they delay them for, very different from study to study. Next was a study by Saltzman et al. In 2018. And he was also looking at early motion versus delayed motion. And he found pretty much the same thing. So they both lead to comparable functional outcomes and re-tear rates. So essentially, if you do early versus delayed passive range of motion, kind of end up in the same place long term, right? The other thing that they did find was that early motion may result in greater re-tear rates, particularly with large tear size. So similar to the last study, and one thing that we have to be on the lookout for as physical therapists is if you're working with a larger rotator cuff tear, chances are you have to slow things down a little bit. Matlick et al. In 2021 also tried to answer this question. And essentially, they were looking at 13 studies, right? And 6 of those studies favored early mobilization. So early mobilization groups had improved outcomes, greater range of motion up to 6 months, postoperative reduced pain levels, and reduced postoperative stiffness. The other 7 studies demonstrated no significant differences in outcomes. So just to summarize this information, it seems like in some studies, doing earlier passive range of motion is going to be beneficial with range of motion pain and stiffness. In some of these studies, it shows no difference between groups. And the other piece is that in larger tears, you may end up increasing re-tear rates, but that might not happen in small to medium-sized tears. So what's the difference with accelerated versus conservative rehabilitation programs after surgery? So Longo et al. In 2021 set out to answer this question, right? So he's looking at a lot of different studies. And the definition of conservative rehabilitation was basically having complete immobilization of the shoulder for 6 weeks, right? So that's a very, very conservative approach. Basically, don't do anything with your shoulder, put it in a sling for the first 6 weeks, right? The second group was called the accelerated rehabilitation group, and they gradually reintroduced movements before the 6th week. So, group one, don't do anything for 6 weeks. Group two, do stuff before 6 weeks. Is there a difference in outcomes? So, I think it's important to actually talk about the type of tear that was in this study. Like we said previously, there's a difference between a small rotator cuff tear and a large one. So, in this study, they were looking mostly at full thickness rotator cuff tears. I went back and tried to look into some of the studies that were cited in this analysis, and I couldn't find the types of tears in every single study. There's a lot of them, but largely it looked like we were dealing with full thickness rotator cuff tears, right? And what's also a little confusing is that active mobilization was started at different time points in different studies, right? So in some studies, two of the studies included in this particular meta-analysis, two of these studies, folks were able to perform active range of motion immediately after they've had surgery, right? Two of the studies were able to start performing active range of motion at week 3. In two of the studies, folks were able to perform active range of motion at week 4. One of the studies, folks were doing active range week 5. 4 of the studies, active range at week 6. And 3 other studies were unspecified. Okay. So again, this actually makes it pretty challenging to look at this meta-analysis and get a lot of meaningful information from it, just because they're taking protocols that are having people start exercises, different exercises at wildly different times. Okay. In this same study, folks were starting strengthening exercises in different time periods as well. In 4 of the studies, folks were starting strengthening somewhere in the 4 to 6 week range. In 2 of the studies, they were starting strengthening in the 8 to 9 week range. In 3 of the studies, they started strengthening at week 12. In 2 of the studies, they started strengthening at week 16. In 3 of those studies, they started an unspecified time. All right. So we get a general idea of early versus delayed in this study. But the other piece is that you have to take these studies with a grain of salt, just because everyone's starting their active range, their passive range, and they're strengthening at different times. So it's really hard to tell what aspect is leading to a poor outcome or good outcome. So overall, what did they find? There was no statistical significant difference in the re-tear rate among the accelerated and conservative groups. There was improved external rotation at 3 and 6 months of follow-up in favor of the accelerated group. So a little bit better range of motion in the accelerated group. Once you adjust this data for the tear size, particularly in large tears, large lesions, there is increased number of re-tear events in the accelerated group. And tear size may influence the early postoperative rehabilitation outcomes for tears that are large, so 3 to 5 centimeters plus, right? The other piece is that this evidence was mixed. So large tears in accelerated groups in some of the studies had a greater re-tear rate, and then large tears in other studies with the accelerated group had the same outcome, right? So I think that's just important to keep in mind. However, this does kind of tip my hat to the thought that, all right, if you have a large tear, maybe we're not going to go as accelerated, because if we delay things, it's probably going to be a little bit safer. Tire 4 in 2019 also tried to answer the same question. What was good about his study is that he was looking at partial thickness rotator cuff tears. Now, in the last study, the studies included were majority large, full thickness rotator cuff tears, right? However, partial thickness are different. They're a little bit smaller. And what you'll see is they tend to do a little bit better. They have a lower re-tear rate. Generally speaking, I think they have a little bit better outcomes, right? So what happens, accelerated versus conservative treatment of these partial thickness rotator cuff tears. And what they found was that in the accelerated group, they had significant improvements in active range of motion, both at 6 weeks and 3 months. They had less postoperative stiffness, and there was no evidence of a higher rotator cuff re-tear rate. Okay. So in my mind, what this gets me to start thinking is that if you have smaller tears, especially if they're partial thickness tears, after you have rotator cuff repair surgery, we can probably go a little faster with these guys. We can go with a more accelerated program. So in this study, what was the accelerated PT protocol? Like I said, these research studies include so many different studies with different protocols. It's really hard to put your finger on what's okay versus what's not okay, right? So in the accelerated PT group, they use a sling with abduction pillow, and they use it during the daytime for 4 weeks. And at nighttime, they use it somewhere between 2 and 4 weeks, and then it was discontinued afterwards. In the standard PT group, they were using the sling for 6 weeks continuously. In the accelerated group, for passive range of motion, they started passive range of motion 2 to 4 weeks, and they utilized pendulum exercise to start, right? In the standard PT group, they used exclusively passive range of motion for the first 6 weeks in the form of pendulum exercises, right? So in the accelerated group, they began active assist range of motion weeks 2 to 4, whereas the standard PT group was doing passive range for 6 weeks. They didn't begin active assist range of motion until they got to 6 weeks post-operative. In the accelerated PT group, they were beginning active range of motion at the 4 to 6 week mark, whereas in the standard PT group, they were starting active range of motion in the 3 to 6 month period, which is actually a very long period of time to wait to start active range of motion exercises after rotator cuff repair surgery. So I think in some ways, this study is not fair from that standpoint, just because the standard PT protocol is so conservative, whereas the accelerated PT protocol is accelerated. But if you compare this accelerated PT protocol with the more moderate standard PT protocol, you might not see these same differences. And lastly, in the accelerated PT group, they were beginning strengthening at 6 to 8 weeks post-op, and they had no restrictions after 8 weeks. In the standard PT group, they were beginning strengthening exercise at 3 to 6 months post-operatively. Again, that is mega conservative. So take this information with a grain of salt. If you had a more moderate standard PT protocol, you might have similar results to this accelerated protocol. Who knows? What factors affect rotator cuff repair healing after surgery? So essentially, after you have rotator cuff repair, you have some sutures that are going to attach the tendon back down to the bone. So the concern here is that over the course of time, this tendon might re-tear back off, or maybe the tendon just doesn't heal back down to the bone. So there are a variety of factors that are going to influence whether or not that tendon heals back down to the bone. And we know those. So we have some medical research to show this. So one, your age is going to influence this. The older you are, the less likely you are to heal well. That makes sense. The surgical technique is also going to affect this. So if you have a single row procedure, it might not be as strong as a double row procedure. We have some research to support this. So the double row repair has been shown to have better biomechanical strength, footprint coverage, and radiographic healing rates. Next, if you have diabetes, less likely to heal quite as well. If you're a smoker, you're less likely to heal as well. If you're trying to get back to manual labor over the course of time, you're more likely to re-tear. Makes sense. Basically, that rotator cuff is going to be asked to be doing more over the course of time than someone that's more sedentary, or at least doesn't do a bunch of manual overhead activities. The size of the tear is going to greatly affect the risk of re-tear. So a small tear, low risk of re-tear. If you have a massive retracted tear, much higher risk of re-tear over the course of time. Tendon quality is also very important. So like I said, did the tendon retract? That's important. Fatty infiltrate is going to be another thing that's going to affect the healing rates. So essentially, after you have a full thickness rotator cuff tear, the tendon tears off of the bone, the muscle that attaches to that tendon starts to become filled with fat, and then you'll get some atrophy of the muscle itself. So if there's a bunch of fatty infiltrate into the muscle with atrophy, then the likelihood of this healing over the course of time after repair just goes down. So this brings us to our next point. And this is probably the biggest takeaway with this entire Fitness Pain Free show. Essentially, you should use your brain when you're trying to figure out how fast or how slow you should go with your rotator cuff repair patients, right? So there's a variety of factors that we know that can influence your healing rates, your re-tear rates, et cetera. And there's a variety of different things we know that are going to be helpful to help you heal a little bit faster, right? So essentially, we can speed things up or slow things down based on these variables, okay? So what are some of the variables that when they're present, we have to think about slowing down our rehabilitation after rotator cuff repair? So one, age. Older folks don't heal quite as fast, so we probably have to go slower. If you have a single row repair, doesn't necessarily attach the tendon down as well as a double row, so we may have to go a little slower and wait a little longer for that tendon to heal down to the bone. If you have a history of diabetes, or if you're a smoker, just not going to heal as well. Okay, so probably it's going to take a little bit longer. If you're trying to get back to manual labor, and I would also lump athletes into this as well, we probably have to delay our rehabilitation a little bit. And this is simply because we're going to be throwing a lot more stress at the shoulder if you are manual labor returning to work, or you're an overhead athlete like a baseball player returning back to pitching, right? So we need a little more time to establish some more strength in that area. Okay. The next piece is the size of the tear. So if you have either a large or a massive tear. So massive tears are going to affect multiple tendons and just a bigger tear in general. There's also more likelihood of that being a retracted tear, right? Also, there's more likelihood of there being more fatty infiltrate and muscle atrophy. If any of these things are present, we probably need to slow down our rehabilitation. Now, if we have a lot of these things present, so let's say I have an older individual, single row repair, they have diabetes, they smoke, they're trying to get back to manual labor, plus they have a massive tear, multiple tendons involved, a whole bunch of fatty infiltrate. I need to go dang slow with this individual because the risk of re-tear is very high. And I'm trying to do everything in my power to make sure that we have a successful outcome, right? But if I only have, let's say, one or two of these things present, maybe I don't go quite as slow, right? I can speed it up just a touch. So, what are some of the factors that, when present, kind of pushes us to this idea of an accelerated rehab protocol or just a faster onset of passive range of motion and/or getting the sling off a little bit faster? Well, for one, younger age. If you have a young buck in front of you, chances are they're going to heal pretty well. The re-tear rates are going to be a little bit lower. Okay. Next piece is a double row repair. We know those are a bit stronger. So maybe we're able to be a little more aggressive in the earlier stages of rehab. If someone is a non-manual laborer or an athlete, let's say you have a young student that just wants to get back to life and they don't care about getting back to any sort of manual labor at all, any sport, we can probably go a little faster with these folks simply because we're not going to be putting a ton of stress on that cuff because they're not going back to tough things with the shoulder. If you have an individual with a small to a medium tear, chances are they have less likelihood of re-tear if we go a little bit more accelerated, right? If this individual has a partial thickness tear, same thing. We're less concerned about a re-tear, and we may actually improve their range of motion earlier on and have less stiffness and pain after the surgery, which is definitely a good thing. And the last thing that we're looking for to try to accelerate folks is going to be tissue quality. So if someone doesn't have any fatty infiltrate, there's no atrophy, there's no retraction of the tendon, that's all a good sign. Healthy tendon, probably going to heal back on really well to the bone. We can probably utilize more of an accelerated approach with these folks. So now that we've established that not all tears should be created equally, how do we go about actually getting this information? Because largely when someone comes through the door in the physical therapy clinic, chances are, they're not going to have all this information on them, right? A lot of folks don't even know what type of surgery they've had, right? Let alone what their tissue quality was like prior to surgery. So I think it's very, very important that you communicate with the surgeon so you get an idea of what the repair was like, right? So what kind of questions can you ask the surgeon so you can have a better outcome with your patient, right? So first and foremost, you ask, what type of repair was this? Okay. Was this a rotator cuff repair? Was this a labral repair? I mean, it usually comes with a PT script, but every once in a while you don't have a PT script or you can't read the PT script, right? Or the patient can't remember what the surgery was, right? I know it sounds crazy, but it happens more often than you like it to be, right? Next thing to ask is, what was the size of the tear? Are we dealing with a small tear? Is this a medium? Is this a large? Were there multiple tendons involved, right? Is this a massive tear? Also, is there any concomitant pathology, right? Some folks will come in, they'll say, yep, I had a rotator cuff repair. And you'll ask, was there anything else that was going on with the surgery? And they'll say, nope. And then you go speak with the physician and they're like, oh yeah, we did a biceps tenodesis with that, which essentially means you can't be doing a whole lot of direct bicep work early on. So I think it's very important that we just know exactly what we're dealing with, right? What type of surgery? Was there any concomitant pathology? Am I dealing with a labral repair in there as well, right? We need to know that because you might have to be careful because of the rotator cuff, but you might also have to be careful because of something else they did surgically, right? Another good question is, what is that tissue quality like? Was there any retraction of the tendon? How large was the space between the tendon and the bone? So they can actually tell you how much retraction there was. It could be slightly retracted or big time retracted, right? If you have a lot of retraction and that tendon quality, tissue quality is really poor, it's actually pretty tough to pull that tendon back and reattach to the bone. And it's probably a little bit more likely to re-tear over the course of time for that reason. I always ask for a protocol, right? So essentially, what does the surgeon want me to do? What do they not want me to do? And I want to make sure over the course of time, I'm not overstepping their boundaries, right? Every once in a while, you get like a absolutely crazy protocol that doesn't make a lot of sense. And you think that it's maybe doing a disservice to the patient, right? And you can reach out to the doctor and just say, hey, I'm seeing this on the protocol. Is this something that you firmly believe in? Because sometimes what happens is that a patient will be sent to your office with a protocol And the protocol was just essentially taken from Google. It's not actually from that surgeon. So I would say reach out to the surgeons if you aren't already. Try to establish a relationship. See if they actually, believe in the protocol they're giving to their patients. Because if you're an informed physical therapist and you are concerned that someone is maybe going to get a little too stiff if we wait too long, right? Maybe the doctor is mega conservative for a small partial thickness tear. And you want to get them going a little bit sooner. Just reach out to the doctor. Make sure you communicate these things. I would not go over their head, right? We are in a litigious society. If this does re-tear and the patient comes back and puts a blame on you because you started active range of motion at week 4 and the doctor said don't do it until week 6, right? I know that stinks, but you have to be very careful and cover your butt, basically. So let's talk a little bit more about return to sport after rotator cuff repair. So in this study, they were looking at partial thickness tears that were greater than 50% torn, right? So generally speaking, partial thickness tears in general, but especially less than 50% torn, usually don't have surgery with these, right? Generally, they're treated conservatively. We don't have to cut these folks open immediately, right? Thing is, in most athletes, they tend to be younger, right? So the majority of folks playing sports are not 65 to 7-year-old, right? They're somewhere between, let's say, 15 and 20, okay? And the thing about rotator cuff tears is they tend not to happen until later in life, except if you play an overhead sport, then they happen a little bit faster. But that being said, usually you'll see smaller cuff tears in younger patients simply because they're not old enough to start acquiring these tears, right? So in this study, they were looking at repair of partial thickness tears, right? Greater than 50%. Do keep in mind that this is not as severe an injury as, let's say, a full thickness cuff tear. So you take this data with a grain of salt. What was cool is that they took these patients, they put them into 4 different groups, right? And they were basically putting them in the buckets based on the sports they played. So they had a non-collision, non-overhead shoulder sport group. They had a high impact and collision sport group. They had an overhead sport. They didn't differentiate between, let's say, volleyball or tennis or pitchers, which we'll talk about a little bit later in baseball. And they also had a category for martial arts, right? What they found largely was that 87% of those folks were able to return to sports, and 80% of those people returned to sport at the same level. Okay. That's actually pretty solid. The average return to sport time was around 5.6 months. And they also said that functional outcomes were not related to the type of sport or the level of competition before the injury, right? So if you were a professional athlete, it doesn't mean that it was harder for you to get back to sport compared to just a recreational athlete that's not necessarily playing at a very high level, okay? However, this is just in one study. This evidence is a little bit mixed, obviously. All research is a bit mixed, but at least in this study, didn't show a difference. Anderson et al. In 2020 put out a meta-analysis of 347 athletes, 81 of which are competitive, and 266 of which were recreational. And they were trying to decide if there's a difference between returning to sport if you were a recreational athlete versus a competitive athlete, right? So if you want to get back to a very high level of play, maybe you don't have that same positive outcome compared to someone that's trying to get back to a lower level of play, right? So they're looking at a variety of different sports. The biggest sport included was baseball, then golf, then football, and then tennis, right? And what I will say about the baseball subgroup, and you'll find this a little bit smattered across, our medical literature. If you want to look at any of these publications, I have citations. They're all going to be in the show notes if you want to check them out. So essentially, outcomes after rotator cuff repair in overhead athletes are significantly poor, and return to sport remains unpredictable when compared to other populations, right? So if you're a baseball athlete trying to get back to pitching, you might not have the best outcome generally. Position players, maybe they're a little bit better, and sports that don't require pitching, probably going to be a little bit better too, right? But at least in this study, what they found was the overall rate of return to sport at a similar level of play or higher was 70%. Okay, so relatively decent, right? 2/3 of folks are getting back to their sport, right, at the same level of play. What they also found is that 73% of recreational athletes got back at the same level of play, but only 60% of competitive athletes were able to return, right? So at least in this study, what they found is that if you were a more competitive athlete, you're less likely to get back at the desired level of play than someone who's more recreational, okay? And the other piece, and I kind of alluded to this previously, in this study, a subset of 43 baseball and softball players across 4 studies yielded a 79% rate of return to sport. However, only 38% returned to the same level of play or higher, right? So essentially, if you're a baseball player, especially returning back to pitching, rotator cuff repairs is a tough thing to recover from, and your rates of getting back at the same level of play are probably going to be diminished, right? This is not to take away hope from folks, from pitchers that get rotator cuff repair, but it is one of those things that's in the back of my mind when I have a baseball pitcher who has a rotator cuff tear. I'm deciding whether or not the best course of action is to refer for surgery or try to do something more conservative. So, how about return to sport rates for CrossFit, right? This is fitness pain free, right? I specialize in fitness, strength sports, barbell athletes. If I am involved in those sports, right, and those activities, I love CrossFit, I love Olympic weightlifting, powerlifting. What's going to be my return to sport rate? Well, there was a cool study by Cardone et al. In 2020, and I've actually done an entire fitness pain-free show about this study. So I'll leave a link in the show notes. You guys can definitely check that out. But what was really cool is that they were looking at return to sport rate of CrossFit athletes, right, after rotator cuff repair surgery. Okay. Now, a small study, only 22 CrossFit athletes, but it was pretty cool because those guys were pretty intense. I think they were spending somewhere like 8 to 10 hours per week worth of training, which is more than the average recreational person. They had a single row rotator cuff tendon repair. I believe they had partial thickness as well as full thickness tears in the mix. And what was really cool is that 100% of these individuals returned to intensive CrossFit training. So return to that same above recreational level of participation, right? The average time for return to sport was 8.7 months, plus or minus 3.4 months after surgery. That range was somewhere between 6 and 15 months. 59% of individuals indicated a return to fitness at a higher level than they started. That's really good. 32% returned at the same level, right? And only 9% returned to a lower level. So at least what's pretty cool about rotator cuff repair in CrossFit athletes is that the majority of them are going to get back, and the majority actually get back at the same or higher level of function. A small bit of those folks are not going to get back to the same level, but largely that's a good outcome, right? So if you have a big rotator cuff tear, you're a CrossFitter, I'm a little less likely to be scared of you getting a rotator cuff repair because we know these tend to do pretty dang good. If you guys are liking what you're listening to right now and you want to continue with the rolling, I have another video for you. It's called When Do Rotator Cuff Repairs Fail? So unfortunately, a chunk of these rotator cuff repair surgeries will fail, right? And it's important as physical therapists to know when these are actually occurring so we can be a little bit more cautious during this time period. So I'll leave a link above my head and go ahead and learn a little bit more about when rotator cuff repairs fail after surgery.